Hey, hey, welcome to Coochie 101 Part 2. Libido after 40, the low down on libido. If this is your first time here, welcome, 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 because we gonna tell you what the real deal is. We're gonna talk about what's really something that doesn't get enough press. What turns you on? What's your sexy spark? All of the above. So it's okay if you don't feel like you used to. Sex feels like a chore, or even it's just off the radar. A lot of times things definitely get overhyped, overstimulated, like it's some kind of Hollywood movie. Every time you just look at the person, you just melt and you just jump right on them. No, that ain't how it is. And we know things shift after 40. Hey, girl. Hey, I see love is my superpower on here. I see Doretha on here. Thanks for joining me. I really need to, if you have some people that don't want to talk about, have not talked about this, don't know where to start, and need this information, you need to go ahead and tag them so they can get it. So if they don't hop on a live, they may not, you might be able to get it into the replay. Let me back up. My name is Dr. Letitia Williams, licensed physical therapist, pelvic floor therapist, and menopause coaching specialist. So, what is that? Let's back up on there. So, let's talk about what libido actually is. We can break it down into like 3 different parts. We have hormonal drive, we have physical readiness, and then we have mental and emotional desire. So for hormone drive, that's kind of pretty much what you would expect. It's influenced by estrogen, testosterone, your thyroid, and your stress hormones. So combination of things can play a role when you're talking about that hormonal drive component. 2, physical readiness, blood flow, lubrication, nerve sensitivity, pelvic floor tone. So pelvic floor muscles, bottom of your core. All your pelvic floor muscles have to work in concert together to help you relax when they need to relax, tighten when they need to tighten. And then, as we talked about last week in Coochie 101, we went through the anatomy. So your vulva, which is everything on the outside, external, vagina is everything inside. So important aspects of your vulva is your clitoris and clitoral hood. That's where we're getting lubrication and where we hit arousal is key in that area. Physical readiness. So we also said blood flow, we said lubrication, nerve sensitivity, pelvic floor tone. Nerve sensitivity changes as we get older. So going through perimenopause, menopause, and beyond, the tissues of our vagina and vulva, they begin to thin. So we start losing some collagen because of that estrogen protection. When you have that thinning, we have a highly sensitive area that now is thinning and doesn't have the same protective measure. That's where we can start having irritation. Also, lubrication starts going down. So them times when you used to be Faucet City, now is desert plains. That is those changes that are occurring due to estrogen dropping and not being produced. So that thinning of the tissues can make intercourse painful. The lubrication, you don't have that lubrication, also not comfortable. And we have many women that are suffering in silence right now, thinking, hey, I want to do this for my partner. I'm just going to suffer in silence and just grin and bear it because it is what it is, and I'm old now. Baloney. I'm not falling for it. And I don't want none of y'all to fall for that either. It was a funny story. I had a client, and she was over the age of 65, or she 65. And somehow it came up. I tend to, meet people and they tell me things. And I guess have a face that's comfortable and trusting. And I do enjoy that. But she told me, and I said, "Ooh, I'm going to make that my goals as well. She said, I'm 65 and my coochie is still juicy. I said, okay, I'm with you. I want to be there as well. So guess what? You don't have to suffer in silence. You don't have to just put up with it and take out the whole aspect of your own pleasure as well. Come on, ladies. This is something that we do not talk about. So even if you look at the industry and you look at male sexual dysfunction, Viagra, we got the blue pill, we got the extends, we got all the things. Do we have options, or how much money is put into options for women? It's probably so nil that you can't even find it. I believe it was some type of, I want to say it was close to $3 billion in the male dysfunction category. And if we wouldn't even talk about just women's health research and funds going on there, it's so low. And then a lot of times the women's health research is not for menopausal women. They're not having money going towards better options. So if you start having menopause symptoms at 35 and you stop having your last cycle 51 to 53, that's about the average age. Anything before 45 is going to be considered early menopause. So after 45, if you're happy, no more period, you're now postmenopausal. So you're always going to be menopausal. So it's always fun when people say, oh, I've already gone through that. I'm done with menopause. You're not done with menopause. You're in menopause for the rest of your life. I saw that in a documentary and I was like, you are correct. You are in menopause for the rest of your life. So if you're 50, 51, do you want to have zero sex drive, zero intimacy, and grin and bear it for how many more years? And we live longer too? No, that's why we need to be having these conversations. So the last three in the libido is going to be mental and emotional desire. That could be a number of things. That's feeling seen, safe, connected, confident. All of these things can potentially be challenged in regular everyday life, definitely going through the menopause change. We got brain fog, again, night sweats. We're now saying, oh man, I'm starting to gain weight in areas that I had not before. Or now we're attached to having a cycle was, hey, that was my, shining and that's what made me a woman because I was able to have children. Or now you have kids that now you're empty nesters, and different transition occur there where now you and your spouse, you had a lot of time together. And if you were really attached to everything kids, and didn't continue to develop in relationship with their spouse, now we're also going through some different transition time at the same time where our hormones are going all wacky. Yes, ladies, we get the fun things. So low libido isn't just about hormones. It's also about life, stress, relationships, and body image. All things that could, like throughout a life cycle of a woman, I'm sure we've all combine all those things together. And I'm going to bring in my little friend here. This is one thing. If you know, ladies. Drop down in the comments why you think I have this pineapple. That's all I'm going to say. I know I got 5 people. Go ahead. Why do you think I have this? I know y'all know. Don't be acting shy. Don't be acting shy over here. Okay, yes, I see it. Okay. But guess what? That's a myth. Yep, gotta break it on down for you. Eating pineapple, we've heard it. Eating pineapple will make it taste better. It will change the smell. But no, there's nothing that's actually been proving that show that. So let's pull that on out of there. The taste or the smell of your actual bodily fluids are dependent on the hormonal cycle of your body. Get that. And to me, this myth just further perpetuates that your vulva, your vagina stinks, and there needs to have some extra flowery smell to it. So some of y'all, you don't have to respond, but let's say, how many times has that stopped an individual from tasting that area due to your smell? Pause. Ain't stopped one thing. Has not stopped one thing. So this whole thing that we had to be flowery and put it up in a bow and do all these things, that is something that's totally driven by other and external forces. So I definitely like to bring that in there because there's nothing that says. Now, are we going to talk a little bit about nutrition and how that supports your vaginal health, libido, which in turn can help with libido as well? Yes, I know there's probably a lag. Somebody said, sis, yeah, hey, I told you I'm going to tell it. What you been thinking? What you ain't saying? I'm going to tell it. So, yes. So of those 3 parts of libido, what part do you think affects you most right now? Is it the hormonal? Is it the physical? Or is it the emotional? Let's drop that down in the comments as well. When I talked about the 3 stages of libido, do you think right now, is it hormonal for you, physical or emotional, or is it a combination of all of them? And at different phases, that could be. So you can drop your responses down into the comments as well. We'll go back through those. Libido, we'll break it down to 3 parts. Hormonal drive, influenced by estrogen, progesterone, thyroid, stress hormones. Physical readiness, blood flow, lubrication, nerve sensitivity, and pelvic floor muscle tone or strength. Or 3, mental/emotional desire. Feeling seen, safe, connected, or confident. So 3 different ones. So drop your answer down there if you think what's potentially impacting your libido, those 3 parts. Love to see those answers in there. So let's talk about what happens after 40. So changes that impact desire. Decrease in estrogen equals less natural lubrication. There are some great products out there. One I personally recommend, and I say personally, I mean personally, is Good Clean Love, and it's a water-based lubricant. Any clients I have, any recognition I have, I most likely have tried it. So that is a good product. Want no more information about that? I do have a gang of free samples. Holla at your sis for that. So other things that impact desire. Drop in testosterone. That is going to impact your desire and your sensitivity. So yes, women do have testosterone. Is it the same level as men? No. And you don't even realize that if you have low testosterone, that is going to impact desire. And is there treatments for low testosterone? Yes. The key is going to a menopause-informed provider. That most likely is not going to be OBGYN. Definitely not going to be your primary care physician, so that you can kind of discuss these options and have a roadmap built out for you as well. I'd love to be able to have some conversations with ladies. Obviously, I can't prescribe, test, and do those things, but we can definitely lay out the plan and say, hey, this is some things you need to be asking this particular provider. And I have at least 2 providers that are here in the Indianapolis area that can help you get a plan and help you address those things for sure. So what else is occurring? Vaginal dryness or pain, both of them. That can also make sex just less appealing. No, it's painful. there's no lubrication. So of course desire is going to be low. So of course you're going to be least likely to want to engage in sexual activities, as well as like, oh, this is painful. Hope they, let me get in the bed and hope they fall asleep. It don't bother me. But that's not what you desire. If that's not what you desire, then let's do something about it. And let's have the best quality of life that we can. So we also have that impact of those body changes and potentially fatigue, those shifts in how you feel in your skin. If you're not feeling the greatest of yourself and your mind is like, ooh, I am just not liking what I'm seeing in the mirror. Of course, you ain't going to be feeling sexy, fine, and turned on and juices flowing and all that. That is another impact that, in general can have an impact, but it can really have an increased impact in that menopause transition phase as well, because there are times where there is an increase incidence of anxiety and depression during this time period. So you're not alone, you're not crazy, and there's options for you, things you can do. We also can add in, you could be in that spot where now you have added stress at work, you're in the prime of your careers. You also maybe have flipped to a caregiving mode if you have aging parents, and you still maybe also have children that, that are in their home and you're supporting. And then just that increased mental load, major libido killers. Just, I'm too stressed out to be thinking about any of that. Don't look at me. I'm just trying to go to sleep. But we know that's not good. That's not the greatest quality of life. So, even if you've had kids, any trauma or any pelvic pain, you may carry fear or disconnect around sex. Now, there is that my direct line is being able to look at some of those psychological factors. No, but there are also sex therapists. There's also providers that can dig into a little bit more into some of those social aspects. Now, as a pelvic floor physical therapist, the pelvic pain, yeah, that's me. Pelvic pain, issue with dryness, lubrication, pain with insertion or during or after intercourse, that's me right there. Pelvic floor physical therapist can help with that. So the key here is not to be thinking about, oh man, this is going on with me and I'm just, really on the struggle bus. The key is to know that you're not broken. Your brain and body are responding. Are responding to what you've been through, but desire is something that you can reconnect to. Desire is something that you can reconnect to desire. If you've been getting some couple little gems in here, say, ouch, or wow, in the comments. Pause there. We're going to talk next. I'm going to talk next about what can you do. Let's talk a little bit about some lifestyle changes, and then we're going to talk about a little bit about what I prefaced on some people, that female Viagra. So, what can you do lifestyle related? I know many individuals want to do everything they can naturally, or what they say without medication interventions. A lot of things that you can do without medication intervention, you can do those things. And there's also some things that if you are having some impact in your quality of life is decreasing, then there is some options that you can definitely take a look at. So lifestyle changes that can help: regular movement and adding in strength training. So other things that occur when you're thinking about, oh man, I'm giving that abdominal weight gain. This is the largest weight I've been in my life going through this change, me included. And we think, oh, now I just have to eat less, or I'll just kill myself with cardio. All I got to do is just go for a walk. Cause that's all they say. You go there and like, oh, just go for a walk. That's the best exercise you can do. Walking is great, But walking is not going to translate into, hey, when I'm getting older, I can't even pick up this case of water, bring it out the trunk and bring it to the house. I'm getting tired going up and down the stairs. I can't get out of my chair. I can't get off of the toilet. Those require strength. Walking on the treadmill is not going to equate to how am I going to be able to raise myself up out of the seat or be able to carry groceries back and forth, pick up grandkids, whatever it may be, go on the family trip you've been wanting to go to in Disney, and you have to hike and you have to walk all these time. You have to carry bags and things. So people always think of, oh man, if I do weights, I'm gonna get all bulky and I'm gonna look, manly. It's far from it. You have to be able to institute some specific strength training into your plan. Yes, cardio, walking, doing those things, all great. I'm not saying don't do those things, but an added piece in there, even if it can help with weight management, is going to be adding weights into your plan. So next, hey Gina, thanks for joining. Next is prioritizing sleep and stress management. Easy to say, huh? Like, well, you're having hot flashes. I'm waking up at night. I have insomnia. I'm not sleeping. Duh. How am I going to prioritize sleep and stress? I'm stressed because I can't sleep. I'm also stressed out because I don't want to have intercourse because it's painful and it hurts and I'm dry. All the things are going on. And you're also thinking about the umpteen things you have to do tomorrow, next week, next quarter, next season. that shut off time to be able to know that, hey, it's time for rest. So I found that prioritizing sleep and having more of a set schedule, what the nighttime routine looks like, or at least trying to do it consistently, because I'm definitely one of those people that can have my laptop working, in the bed, shouldn't be TV on, phone on. I got 3 different devices on at the same time. I'm working all the way up until it's time to go to bed. And then I'm wondering why I can't sleep or why I'm having difficulty sleep. So setting up a sleep routine that you can figure out, hey, this is something simple for me. Oh, I read right before bed. I do watch a calming show. I turn on YouTube and it has the storm, gentle storm and rain that helps me calm down. Pray, meditate, stretch, sex. Yes. All things that can help you prepare for bed. But go up until the last minute and then try to tell your body to shut off. It's a hard thing to do. It's a hard thing to do in that shut off. So really taking time for self, and I've really been trying to focus on that for myself as well, kind of for these last 8 months or so. And it's a work in progress. From a go person who is constantly trying to stay moving, it's been difficult to be able to do that. But prioritizing that has been really helpful. Also, sensual self-care. So that could be body oil, it could be dancing, that could be anything that you want to put into that. I also want to preference is that a lot of time, even if you're talking about what's normal and what's not, or what, what your vulva or your vagina look like normally. I forgot I have my little model there. I'll briefly kind of go back. This is not when it's normal. This is just a model. So from here, this is if you were looking from below, or if you had a mirror. A lot of times you don't even know what your anatomy is or where it's at or what it's supposed to look like because you haven't seen it. So I encourage you to definitely get that mirror and take a look so you know what's going on. So like I talked about before, make sure I'm pointing correctly because I'm backwards now. On the outside, everything on the outside, vulva, this is the clitoris and the clitoral hood right here. You'll be able to see top is your urethra. That's a pee hole. Inside, vagina, tampon, sex, childbirth, and then here, booty, anus, poop, all that. So all of this red that you see, and including inside, all those are pelvic floor muscles. So there's not just one pelvic floor muscles, and there's not just one thing you can do is sit and just, oh, let's do Kegels. I'm in the car, I'm driving, do my Kegels, and that's all I need. That's another topic there. So understanding, knowing your anatomy, and knowing where everything is located, and you have to be to know for yourself, because how are you supposed to tell someone else what your desires are, what feel good if you are uncertain yourself? Just be totally real about it. Hey, Stephanie, I'm losing my connection. Okay, perfect. My connection got a little crazy. There might have been a brief little pause there. Next, date nights or solo time with zero pressure for sex. If you have anxiety around sex and that's all that's being focused on, you're going to continue to have the same anxiety. So what are the things that can be calming, leads you, that get yourself in the mindset and setting the mood and the tone so that there won't be so much pressure associated with it? Nutrition. Like I said, I knew we were going back to nutrition. So eating supportive foods that increase hydration. Like I said, dry kitty, not happy kitty. Coochie is, if it's coughing, is dehydration. So guess what? What can you do to help support? Because your hydration, your body hydration, also is going to have an impact on what's going on with the coochie. So you're dry, you're dehydrated, you don't drink enough water, you're not supporting yourself with fruits and vegetables, kitty going to be dehydrated. That's going to be hard for the lubrication, for the waterfalls to flow if you're dehydrated. So instead of looking at the newest TikTok fad and thing, oh, drink this for such and such and do that and you'll be good. The basic, drinking water, increasing those fruits that have more water content, fruits in general, vegetables. I mean, those two keys there, fruits and vegetables and hydration, you might already be noticing change with energy levels. So don't be focused on, let me get this good old pineapple and worrying about what something is going to taste like. You got to start with the basic. Even like I said before, that's if you catching this now, you missed my whole deal where the pineapple is a myth. So go back and hit the replay. Go back and hit the replay so that you can learn about that. So let's talk about some of the things that could be one of the elephants in the room when it comes to managing menopause symptoms and having any changes with pelvic floor, with libido, and pain with intercourse. And it's hormone replacement therapy, or now it's called hormone therapy. And people are thinking, is it safe? Oh yeah, what about Greek yogurt? Yeah, if you're talking about Greek yogurt, when you're talking about healthy gut function and having the right type of different cultures in your system that's going to help with your overall body function, yeah, Greek yogurt can be an option, but definitely don't think you have to down yourself with Greek yogurt so they can have a really significant impact or like change things in your pH. Your gut health is going to be directly tied to your energy, your mood, hormone function. Ooh, that's a whole nother deal there. So incorporating foods that help support a healthy gut, you might notice some things even with mental health and mental changes in energy and things like that. So yes, I love Greek yogurt. I do probably have Greek yogurt product pretty often, but I'm using it more as supportive function, and it has a higher content of protein. So protein is one of the things that's going to help support healthy joint support, weight management, and lean muscle mass. So let's talk about hormone replacement therapy. Vaginal estrogen versus hormone replacement therapy or hormone therapy. Hormone replacement therapy got a really bad rap for an article that was misinterpreted, did not have the full content for everyone back in the 90s. It was just like, hormone replacement therapy causes cancer, you shouldn't be taking it, blah, 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 because some of the participants in a study, which they took, I believe, individuals from maybe 40 to 50 all the way up to like 75 or 80. It didn't have an age. They didn't have an age limit, and they didn't have a health history requirement. After these individuals were treated with hormone replacement therapy, there was a certain percentage of them that end up having breast cancer and some other complications. Well, what they didn't say in that was that someone that was 75 or 70 years old that already had heart disease and already had a pre-existing condition, they did not equate for that. So some of those things in the study were showing individuals that already had a history of those things, and then they took hormones. So that then after that study came out, everybody was scared. Nope, don't use it. I'm going to die. I'm going to have heart disease. I'm going to get breast cancer. And then that is not the case. So let's talk about vaginal estrogen, or if you want to talk about local therapy. So that vaginal estrogen, that is going to be a low dose localized estrogen. There's so many different things. There's creams or things like that. That's going to be applied directly to the vaginal tissues. This is applied directly to the vaginal tissues, and it's not ingested and does not go through the entire system. It's local. It's just like if you had a knee and you put a muscle rub or icy hot or Bengay or whatever on there, localized directly to the area. So, like I said, it comes in creams, tablets, suppositories, rings, all different kind of options. But let's guess what? Purpose. So those treat vaginal and urinary symptoms of menopause. So vaginal dryness or burning, pain with sex, recurrent UTIs, which can also be a thing during the menopause, urinary urgency or irritation. They're also supportive for the local estrogen. So even if you had someone that, hey, I've really been on the struggle bus with these areas and I'm still kind of leery about hormone therapy, the direct local therapy is something that you can consider and think about, but with your medical history. So I'm going to talk a little bit some medical history stuff. So the local therapy is considered safe for most people. So even some with a history of breast cancer, but we're going to talk a little bit more of that before. So hormone replacement therapy, that's the systemic hormones, total body. So this is working on your entire body. So it's a hormone therapy that works on your whole body, has estrogen, and includes estrogen and progesterone if you still have a uterus. So if you still have a uterus, you also have to have the combination, estrogen and progesterone. And it can be taken orally, with a patch, gel, spray, or by injection. So the purpose of the whole body symptoms to help symptoms of menopause. These can help with hot flashes, night sweats, sleep problems, mood swings or depression, brain fog. Help support we start lose a little bit of bone loss as well. It helps support negating bone loss as well as joint pain. So this is a system going through your entire system working. And definitely an option to think about if you're having things that are impacting quality of life. If you just don't want to always be carrying a fan around, always looking for where's the coolest seat, what's the coolest clothes I can wear, waking up drenched in the middle of the night, or, you're hosting a meeting and you start having a hot flashing, or you're having incidents where it's like, this is impacting my quality of life, my profession. I don't want to feel this way. Everybody has their own level of what they want to, what you want to handle or deal with. But you don't have to. And you don't have to just say, oh, just wait it out. Don't do that. Don't get in that mindset. So key differences from vaginal estrogen when you're talking about systemic hormones or hormone replacement therapy. The systemic, it affects the entire body. It comes with it's going to have higher estrogen levels. And then it requires careful assessment of risk and benefits based on your particular health history. Got a question. Is it true that if you let it happen naturally, it won't last as long, or is that a myth? No, actually, I'll tell you that. Actually, something that I just learned, there's actually a documentary called The M Factor. And it really is I think it's on PBS, or you just do a search for it. And it's an hour documentary, and it talks about how menopause affects, one of the things it talks about is how menopause affects women differently. And that's ethnicity as well. So we have Asian American, just generally Hispanic. We're not, that's not really an area, but a whole bunch of generally Hispanic, white women, black women. So they talked about the average length of time that each of these ethnicities go through menopause. And guess what? Black women were at the highest. We, on average, go through or can suffer with menopause symptoms for 10 years. White women was like 4 to 6. Asian was like 4 to 5 of there. Hispanic was close to us with, I think, really 7 to 8 years. So letting things just go and suffering through, it's not going to change the duration. Your body's doing its thing with the hormone changes, and it's going to do its thing until it's not, it's not. So, being able to step in and get some support, there's no problem at all. Please doing that, because that's just going to increase your quality of life and get your quality of life back, instead of continuing to wait, because you don't know how long you're sick. And if your symptoms are mild, you're like, hey, I can know. If your symptoms increase, there's no barometer or no way for you to know, like, oh yeah, maybe I'm getting closer to the intense systems not being there. Yes, on average, Black women are 10 years. So please, we can do some things. We can do some things for that. Hormone replacement therapy. A question that comes up is, what if you've had breast cancer? So the total body HRT is usually not recommended for people with a history of hormone-sensitive breast cancer. However, the local vaginal estrogen may be considered in some cases if symptoms are severe, quality of life is affected, and all of these are speaking with a menopause-informed provider, a doctor. Even your general, they may still have that same misconception that hormone replacement therapy is not good for you and it causes this, and that, and the other. Please go to someone that has advanced training in women 40 plus and menopause. I've got two good local providers I can provide information, because they're going to be the one that can do the full assessment to see if it's appropriate for you and prescribe it for you. I work with them when it comes to ladies that are looking, for those options as well. Yeah, because those hot flashes ain't no joke. Excuse me. So alternatives or other approaches. Let me see. I've been telling my doctor for years I was going through menopause. I stopped having periods at 41. I'm 53. Oh, and she's still telling me I'm not. Wow, that's. That's a prime example right there, and we're trying to see why we have some distrust for individuals, some providers in the medical field, because not being seen, not being heard. You are the CEO of your health. You know your body better than anyone else. So really fight. You got providers showing up. Sorry, sis, I'm done. That's no longer my doctor. I gotta find someone that's going to listen and take me seriously, and not to say, grin and bear it, suck it up, it won't last long. You need to relax, drink a glass of wine. Oh, this is all in your head. And that's been going on forever. He said, yes, I need a doctor. That's been going on forever, and if we don't know better, we can't do better. So that's why I'm glad you guys are all here. So there are non-hormonal vaginal moisturizers and lubricants that's for dryness and help with pain as well. There's a couple of different options that, you don't have to go. There's several different options. We'll say that. Also, when you're talking about, there's vaginal insert. There's a bunch of things, but definitely individualized. Also in that grouping, we're not in the medicine grouping, but pelvic floor physical therapy. So what would a pelvic floor therapist do if you're having pain with intercourse? If you're complaining of frequent UTIs, dryness, lubrication is just not there. Several different approaches. So one thing is that if you're having pain with intercourse, pain with insertion, pain before, during, after, a lot of times that's due to, I won't say a lot of times, several different factors go into that. But I can see that a lot of times the pelvic floor muscles are actually overactive. So they're staying tight, not able to relax. Or we also have hip pain, low back pain. Even if you have knee pain, that can have an effect on how your pelvic floor muscles work. So if you think if you have discomfort or pain and you're saying, like they say, go do your Kegels. Kegel, Kegel, Kegel. But Kegels is actually tightening the muscles that are already tight. So that's like, oh, the fire over there. Boom, let's just throw more fuel on the fire. Just throw gasoline on there. And you're trying, I've been doing Kegels and I still pee on myself. I still have to wear a pad or a brief, or I still have to limit my water intake. I don't drink water after a certain time because I don't want to have to pee. Peeing frequently or peeing too much or having those all are some pelvic floor dysfunction. And it's not mama had it, sis had, that's just the way it is. I just had it's because I had kids. And that's just the cross I have to bear because I've had kids, peeing on myself for the rest of my life. No. Or wearing the pins, pads, and just thinking it's just a mom tax. Or thinking I haven't had children, no births, I won't have issues with pelvic floor issues. No, I've had a whole grouping of clients that are in between 20 and 27 that do not have kids and have pelvic floor dysfunction. They're having pain with intercourse. They're having complications from endometriosis. They've had a chronic history of chronic pelvic pain and pain in general. So please get that out of your mind. They're like, I just need to go see them when it's something about babies. I don't need to do any of that. Pelvic floor physical therapy can definitely be something that's comprehensive in a lot of different areas for you to help with some of that. Things that you probably don't think that are connected are having a result of why your pelvic floor and those muscles surrounding them are having an impact. We also have mindfulness and sex therapy. This is especially helpful for desire and intimacy challenges. I also have a sex therapist friend as well. So, when you think about, what is a menopause coaching specialist? I'm like the coach. I can address some things. I got other team members that I direct things to where it's outside of my scope or outside of the things that we can do. So it's leading, helping you build the roadmap for how you want your quality of life to be menopause and beyond when it comes down. So I can't say it enough. Please get a menopause informed specialist when you're talking about addressing these issues. So now taking it back to hormone therapy, who is hormone therapy for? So this is according to the Menopause Society. So that used to be called, I think, the North American Menopause Society. So if you look up Menopause Society, you'll see a lot of the guidelines because they're now one of the authorities when you're talking about menopause. And I take a lot of my guidance from there. So the Menopause Society says that hormone replacement therapy is safe and effective for most healthy women under the age of 60 or within 10 years of menopause if you have moderate to severe vasomotor symptoms. And vasomotor symptoms, those are the hot flashes, night sweats. You're at a low risk for cardiovascular disease, stroke, or hormone-sensitive cancers. Or you want to prevent that bone loss or osteoporosis. Once again, even if you think you fit in some of these categories and you don't know, ask. Go to someone so they can see, because it is individual. So you can't grossly say one way or the other. It's definitely an individual thing. Individual health histories, individual areas that you want to address and help support. So hormone replacement therapy is not recommended for women that have a personal history of breast cancer, stroke, blood clots, or heart disease, unless they're reevaluated individually. Like I said, individually. Also, women well past menopause, unless symptoms are severe and other treatments have failed. So if you're on the far end of it, you definitely have to get reevaluated. I'm gonna say that. You have to get evaluated. So wrapping it up, vaginal estrogen is like, or when it talks about some resources, vaginal estrogen is like spot treating the tissue that's changed. That thinness, potential pain, it doesn't flood or take over the whole system. Hormone replacement therapy helps more comprehensively. Hot flashes, moods, bones, same thing, vaginal area, but it's not for everyone. If you have had breast cancer, you still have options. You just need a provider who listens and knows the guidelines. I can't say that enough. You need a provider who listens and knows the guidelines. So the female Viagra, there are, I think, 2 FDA approved, which I can say, and I won't say heavily, there's obviously FDA approved, non-FDA approved things that are effective as well. And there's FDA approved things that have been taken back, have been recalled, and they're FDA approved. So take that with that. So Addie, I think it's called Addie. That is a pill that can be taken daily for women that have not gone through menopause. So basically it's a hormone-free pill for individuals suffering from what's called hypoactive sexual desire disorder. I know it sounds complex, but basically could be another word for low libido. But this is for if you've not gone through menopause, you've not had problems with low sexual desire in the past, and you have low sexual desire no matter the type of sexual activity. Also, women who have the hypoactive sexual disorder have low sexual desire that is troubling to them, obviously having an impact to them. And it's not due to like, oh, I have a medical or mental health reason or problems in your relationship. Not indicated for that. There's another option. There's injectables before sex for low desire. With any of these options are not the magic pill, and it's not for everyone. See, address probably multiple other aspects before that, or you might have already been having a diagnosis of hypoactive sexual disorder. But to pull it all together, libido changes are common. Libido changes after 40 are common, not shameful. Not a grin and bear it, not a relax yourself with a glass of wine and hope it gets better for the next 25 years. There's no normal sex drive, only what works for you. So if it's abnormal, if it's not like what your normal has been, then that may be something that needs to be addressed for you. There's no normal. It's only what works for you. Your desire, pleasure, connection, and confidence, they're real. They're real options to help with that. So, I saw another comment. That's crazy because my doctor had me taking that for a month. I read that was for perimenopause. Okay, so you're on that. Yes, that's information I have about the Addie, is that it's not supposed to be for women that are beyond menopause. Now, your provider, you know, like I said, get a menopause informed provider, reach out for resources, maybe if you need to try to get connected or anything. So, man, this is love. We covered a lot of stuff in here. I probably could have kept on going. If you learned something and you're watching this on the replay, put in something that you learned, tag a friend. Next week, we're going to be talking about, Coochie care tips. How to keep her healthy, strong, and happy for life. If you want to get access to your recording, I'm going to take this recording, download it, then make sure you drop a thumbs up as well as I got a special little guide if you want that. If you want the guide, Desire After 40. You want that guide, Desire After 40, then holla at me in the comments down there. So until next time, take care of your kitty, be informed, and get your best quality of life, sis. Good night.